the equipment which is used for placing implants, and this is called as a physio dispenser. Why is it called as a physio dispenser? Because physio means it's going to work on physiological tissues, and dispenser means that it is going to dispense a coolant. Right? That's how the terminology physio dispenser is coined. Now, when you see the topmost row here, in the topmost row, you have drilling templates. So if I press the first one, this is for marking. The second and third are for template drilling, when you increase your drills. The fourth is used when you are using a screw tap, where you do not have very high speed. And then the fifth function is inbuilt for implant placement. The sixth function is for placing your cover screw or healing abutment or tightening the abutments. And then you have the rinse function, and we don't need that on a routine basis. Now, in this physio dispenser, you have an option of working either in the forward or in the reverse movement. So this indicates forward and this indicates reverse. I can also do this with my foot control. The foot control also has a feature of changing these programs, also has a feature of forward and reverse. This is for LED light in your handpiece. You can switch it off, switch it on. This is probably for volume. Okay, next important thing which we want to know is the coolant. These 4 drops are coolant, which means one drop is corresponding to 25% coolant flow. So if this is corresponding to 25% coolant flow, the minimum coolant required whenever you are drilling is 75%. Right? Ideally, keep it at 100% because that's very good. You will have excess coolant and the bone does not get heated up. The last figure, what you see here, are the gear reduction ratios. Right? For an implant handpiece, what you require is 20:1. So when you see any implant handpiece, it is mentioned 20:1. What does this mean, gear reduction? This means that the motor is going to work at, say, 20,000 RPM, but what it is going to generate as an output is 1,000 RPM. So this handpiece is going to reduce the gear by 20 times. Right? Because you cannot work at 20,000, 30,000 RPM inside the bone when you are drilling. All of you have used micromotors, right? So when you remove the knob of a micromotor, it kickstarts only after a specific RPM level is achieved. That does not happen with physio dispenser because the handpiece is going to bring it down by 20 times, the gear reduction. Right? So this is about the physio dispenser and the handpiece. Now let us see the implant kit. Now when we see the Dio implant kit, should I put it here? Yeah, I think this is good. So when you see this kit, it's a complete kit where you can place all these implants. And the first row here, you can see the drill called as starter drill, extremely sharp drill, extremely thin. These are the drills which will break if you apply a lot of pressure. So these drills have to be used at high speed and low touch. Then comes your sequential drilling, which is going to increase the size of your osteotomy. The first drill here is a 2 millimeter drill. For this 2 millimeter drill, there are stoppers which are present. So you can put this stopper, and this drill can be used till 8.5 mm, till 10 mm, 11.5 or 13. Right? The stoppers are all interchangeable. Right? Now this drill becomes an 8.5 length drill. It will not go beyond 8.5. Similarly, you can remove other stoppers and put it in the same drill. Next, what you have in the kit is the paralleling pin. We have all seen how a paralleling pin works. You all know that you have to tie it and use it when you are placing two paralleling implants. All further drills, like for example here, this is the drill diameter is 2.7, 3.0, 3.2, 3.8, 4.3. This is the drill diameter. And right above that, what is written is the fixture diameter, right? Which is 5 millimeters, 4.5, 4, 3.8, and then they have two mini connections which are for smaller areas where you do not have good width of bone. All these drills have stoppers in them, right? Which means you do not have that risk of over drilling or tearing the sinus or nerve or anything. They all have stoppers which are inbuilt. Now once this entire layer is covered, for example, the implant which we are going to place now in the dummy mandible is 4.5 by 11.5, right? Now if I want to place this implant at the level of crest, my drilling sequence will start from starter drill. I'll use my starter drill, go in just 2 to 3 mm to create a point. Then I'll take this 2 millimeter diameter drill, put a stopper of 11.5 and go till full length. That will help me achieve my length. Once this 2 millimeter drill is done, out of the entire drilling sequence, I will come to the row where 11.5 is written and I'll use 2.7 followed by 3.0 followed by 3.2 followed by 3.8. This will be my last drill to place a fixture of 4.5. Are you getting the sequence? Now if I have to submerge this implant based on the tissue height, then instead of taking the drill length of 11.5, what drill length will I take? If I want to submerge it, 13. So I go to the sequence of 13. Now if I want to submerge the 13 millimeter implant, what do I do? If I want to submerge the 13 millimeter implant, what do I do? I have to use a drill which is without stopper, right? Only then we will be able to reach that. And for that, you have kits which are zero bone loss kits like these, where if you want, you can put stoppers. You also have stoppers available. If you do not need a stopper, you can take out the drill, use this drill to go into whatever length you want, how much ever submergence you desire. Everything can be easily achieved, right? So anyways, we are going to study these drills in detail later on, but that is the purpose of having a densification kit or drill with you, because they have removable stoppers. And when you want to insert a stopper, you can. If you do not want, you can leave that. Right, so we will start with the basic procedure now. So the first step here, this is the model on which we are going to work. And am I audible? Is it okay? Right. So this is the first step. What we are going to do is make a small incision and raise a minimal flap. Right. So when I'm raising a flap, making an incision, one option is to go, is it visible there? You guys can see, right? So one option is to go mid-crestal, right? And the other option is I can go slightly lingual so that my incision line does not come over the implant, right? So if the incision line comes over the implant, there are more chances of implant infection. But as a beginner, I would suggest you to go exactly at the mid-crestal level. So when we go at the mid-crestal level, we are going to insert the blade to full thickness, right? Going till the full thickness and taking it across to the other side to the distal of premolar. And then going into the clavicular area on both the sides. To raise the flap. Going ahead with a periosteal elevator, we know that the sharp end should always be towards the bone, right? And the blunt end needs to go on the other side, which is towards the tissue. Similarly, on the lingual side, there is a small tissue tag. Now, when I'm doing, osteotomy in this side, now I would need somebody to do the flap. Right, so this is how you would like to see the exposure on the bone, right? Once the exposure is complete and you can see both the buccal and lingual ends, then we go ahead with the drilling. So when I placed this first drill into the handpiece, you always have to remember that do not press the push button of the handpiece. The push button of the handpiece is pressed only when you are taking out the drill. When you are pushing the drill in, you don't remove it. You don't press it. That happens in the operatories also sometimes. So you take this drill, insert it into the handpiece, and do not press the push button. It needs to lock itself. You do not press the push button. Now when I'm going in, now these drills are really sharp. So when you store these drills, keep them in the opposite direction so that it does not hurt you or your assistants. This model has European tissue, more than 2 millimeters thick. So what I'm doing now is I am setting up my speed to a high speed because we are working on a model, and I'm setting up my torque to 35 because this is a model, it usually will resist. Right? So whenever you push this drill in, it is very important that your drill is always in movement when it goes in. You do not stop the drill and then put it there. It always has to be in motion. So with the pilot drill, I am going to just go in 3 to 4 millimeters and not more than that. Right? Is it visible there? Okay. So with the pilot drill, I have gone in by 2 to 3 millimeters. And now, since I want to place an 11.5 millimeter length implant, so I am using my next drill, which is a 2.0 drill, and I am using 11.5 millimeter stopper. Now, what is very important for us to note here is that whenever we are drilling for an implant, there is no finger rest. For all other dental procedures, you take finger rest. Because if you take finger rest in implant, your handpiece will go measly. Right? Which means for implant dentistry, what we need to learn is the elbow movement. Right? The implant goes in with the elbow. It comes with time, so there's nothing to worry. It cannot, if I take a finger rest, obviously my handpiece is going to go measly. So no finger rest in implant dentistry at all. That is why you have drills with stoppers, so that you don't have to worry about the drill going into any other direction. So always try and use your elbow for this. In and out, not applying a lot of pressure, in and out, and cooling always there. Coolant needs to be there. So I've gone in by 11.5 millimeters completely, right? So once the first drill is done at 11.5, now we can easily switch over to the row of 11.5 and use the other drills. Don't do this in patient's mouth. Okay. So the next drill we are going to use is a 2.7 diameter and 11.5 length. Now all these drills have inbuilt stoppers, so you don't have to actually put a stopper and remove it. Right, going in slowly, widening the osteotomy. The problem was that the handpiece is working in reverse mode. right? So with sequential drilling, we are going to take up the next drill, which is 3.0 by 11.5. And once your path is determined, right, once the path is correct, further drilling protocol becomes very easy. Now can you see that my handpiece is hitting the anterior tooth? Right, I'm not able to go the full depth because the handpiece is interfering with the anterior tooth. So what do we do in such cases? We are going to use a drill extension. So your kit has a drill extension. I'm going to attach the drill extension to the drill. Going in to the full depth. So the drill extension remains in place as I go ahead and use my next drill, which is 3.2 by 11.5. See, once the angulation is decided, all other drills are just helping you widening the osteotomy. Right? They are not changing the direction, they are not changing the angulation. The drills become really hot when you are not using saline. So the last drill is 3.8 by 11.5. So when you see the osteotomy here, you can see that we have enough. So when you see the osteotomy, you can see we have enough bone buccally and lingually, and now we are going to install implant into the site. So the first thing is the implant connector, right? So we are using an implant connector from the physio dispenser unit. We are putting the machine driver. I'm changing the torque to, since this is a model, we are putting it to almost 45 NCM and a speed of 30 RPM. This is the implant package, right, which we are going to open up, connect with the handpiece and slightly rotate the vial clockwise. So when you rotate the vial clockwise, you get that connection. What if this implant falls on the sterile drape? Can I use it or not? It falls on the sterile surgical drape. Do I use it or I don't use it? Or what if it falls inside the patient's mouth in saliva? There is a possibility of it falling inside the saliva or on the drape. What do we do? Do we use it or we don't use it? So if it falls on the sterile drape, you can still use it. But if it comes in contact with saliva first, it definitely cannot be used. The first contact needs to be with the blood inside the mouth because saliva is full of bacteria, full of microorganisms. Right? So if it comes in contact with this sterile sheet, you can still, it's okay. I mean, it's not recommended, but you can still do it. But if it falls into saliva, that's it. There is no using of that implant again. Which means when it goes inside the patient's mouth, you have to be very careful to take it directly to the osteotomy and let most of the implant enter into the osteotomy before saliva comes in contact with the crestal part. Right? Okay, so we go ahead with placing this implant. So we always position the implant first. The difference between drilling and implanting is that in implant you always position the implant first and then start your foot control. And allow the implant to go in slowly. Now this is a model, it's okay, but otherwise in patients we need to give time for the bone to expand. And once you achieve the required torque, your handpiece will stop. Right? They have given you this beep, which means the required torque of 45 NCM is achieved. And now I still have one or two threads which need to go in, right? So if it's just one or two threads, I can go ahead and use my hand drivers with a ratchet to install the implant in. But if this is almost half of the implant, then you will have to take out the implant, redo the drilling, and then place your implant back. Right, so I have my implant driver with the ratchet connected. I'm going to connect it inside the implant. Now the most important step is to have a good finger pressure while inserting the implant in. Right, so with a good finger pressure, I am tightening my implant. You have to keep seeing whether it is at the level of crest still or not, maybe a turn more. Now what we were talking about the other day was the dot on the driver. Now when we see this driver, when you see this driver, so when you see this driver, you can see there are flat surfaces on the driver. This is a flat surface. Then you come across the other side, there is a flat surface. So these flat surfaces have to align to make sure that your implants are aligned in the similar hex position. So we'll just check if the implant is, it is slightly supracrestal, so maybe one or two more turns. Right, this is how your implant goes into position, and the next step is to put the cover screw. Right, so once that cover screw is done, for such sites you have basic single interrupted sutures to be done. You're getting the cover screw. So in the meanwhile, when we do the suturing and cover screw, I'll explain you what is the difference between a normal surgical kit and a navigated kit, which means your guided surgery kit. So when you see this guided surgery kit, you can see all these drills, they seem to be longer, right? Because they compensate for the offset of the guide, right? For the dimensions of the guide, they compensate for it. That is why most of them seem to be longer. And if you want to do a flapless surgery, you also have tissue punches in between, right? There are implant connectors which are separate. So the kit is different because this kit is used only when you are doing a guided surgery, which means for guided surgery, you need a good amount of mouth opening. And what is that mouth opening? It's 40 millimeters. If you have 40 millimeter mouth opening in the site where you have planned to do a guided surgery, like if I want to do it in the first molar, I should have 40 millimeters mouth opening in the first molar. If I want to do it in the anteriors, I need to have 40 millimeters mouth opening in the anteriors. That is how this guided surgery is done. So you have all these similar drills, but all drills have got longer stoppers. Right? The purpose of this longer stoppers is to compensate for the offset which is there in the guide. Okay, so once we are done with the implant, we are going to now put the cover screw in. Implants cannot be touched with your gloved hands or fingers because their surface is coated, it is treated. Cover screws are not a problem. So when you set up a cover screw, it is important to put this cover screw not beyond 10 Newton centimeter. Right? So when you do your finger tightening, you will not know the exact torque. So what we can do is I can set it up to 10 Newton centimeter, use my physio dispenser and the handpiece. So I'm going to connect the hex driver to my handpiece. Put it across the cover screw head and you can see that we have achieved a torque of 10 NCM. Now sometimes this cover screw gets cold welded with the implant. That's a very difficult situation. You are unable to retrieve the cover screw. So what you do is every time before putting the cover screw, you need to flush the internal channel of implant because sometimes there is blood inside. That blood will dry up and create friction. Secondly, use Metro Hex gel. Dip your cover screw in the Metro Hex gel and then put it there. So that acts as an antiseptic as well as a lubricant. Right? It does not allow cold welding. Because a very well integrated, well placed implant, if the cover screw gets cold welded, it is all a waste. So never the cover screw should go directly into the implant. It should always be through a Metro Hex gel. And do not forget to wash the internal channel of implant of any blood before you put that cover screw in. Right? So the cover screw is done and now the next step is to suture. So what we are using is a 4-0 suture. Silk. Due to my finger size, I have customized needle holders with me. Okay, so Anyways, tomorrow we are going to talk about suturing also in the first half. So when we suture, what is important in suturing is where am I going to take my first bite, right? So if I am going ahead with my buccal flap first, which usually will be the first bite, other than those areas where you will not be able to enter buccally. So the first bite is around 3 to 4 millimeters into the tissue, right? Ideally you take this out. Do not attempt to close both the flaps together. One by one, if you do not want to tear it accidentally and do not want the needle to enter into different positions. So I am going into the lingual flap again by around 3. Multiple varieties of knots, the surgeon knot, the granny knot. So the first turn, let me show it to you again. The first turn is a double turn, right? Getting it across and making sure that the knot does not lie over the incision line. You do not want the knot to lie over the incision line. It should be slightly buccal or slightly palatal, whatever suits you, but not on the top of the incision line. The third and the final knot is in reverse because that locks the knots, right? So once we are done with this, what should be the distance between my first suture and the second? What should be the minimum distance I should keep in order to make sure that the blood supply is maintained in the flap? Do you have any suggestions on that? I mean, for this side, how many sutures should I do? 1 more or 2 more? With this kind of tissue thickness, 1 more is less because we are going very close to both the corners. So I will definitely require 1 more suture in the center because central area is the area where the implant is placed, and we definitely want tissue approximation to be good in that area. So 1 more simple interrupted suture in the center. So after the flaps have approximated, it is still okay to go ahead and put your needle into both the flaps at a time, but not for your first bite. The first bite always needs to be individual. Right, so this is how the site is closed. So that's one important part which we have seen here, how to do that drilling, how to raise a flap, how to close a flap. Less than that, if you have finalized your drilling protocol, remove the extra drills from your kit. Don't keep it while you are operating. Don't get confused. Just keep those drills, those drivers, those connectors which you require, and then you can keep the kit addition. But as to begin implantology, what you require is a basic kit, and the second important requirement, because you will not, if you wait for basic cases, you will not get cases. People are not roaming around having 10 millimeter width of bone, right? They are roaming around to get implants. So for that to begin, you need this osteodensification per kit. You need a basic implant kit, a physio dispenser, and a few instruments. That's all it takes to start doing implantology. And that is important, to have these things with you: a physio dispenser, a handpiece, an implant kit, an osteodensification kit, and access to CBCT. And if you have all this, go ahead and start doing implants, because basic implantology does not mean that you do search for cases where things are very easy. You search for cases whom you can diagnose. That's it. If you can diagnose and select, make a treatment plan, those cases are well suited for you. So I'll now show you the second exercise which we are going to do in the hands-on. I have a video of that. Can you get me that one?